Well, Chantal really did a fine job in setting up the conversation that we're going to have from my perspective of the ACGME. She is spot on the observations she made, and I really appreciate the cases that she presented. So the guiding principles for ACGME around diversity and inclusion are really just three. The first is that health equity is a means to achieve elimination of healthcare disparities, which is our overarching focus. And the way that we're going to approach this at ACGME, since we're the accreditor of training programs, is to work on a workforce issue. And the goal of workforce diversity is to achieve health equity. And then finally, we're going to focus on some of the things at the end that Chantal was talking about around inclusion, which are the things that she described. And we see inclusion as a tool that ensures that diversity efforts are successful. And if you put those together, it really shows why each is important: diversity, the workforce itself, as an elimination tool for health equity. And what Chantal so elegantly pointed out is what happens when you increase diversity in an environment that's unaccustomed to it. And so what you have to understand is that these environments that only have 3% African Americans or 6% Latinx trainees aren't primed exactly to be welcoming environments. And so we have to figure out how to mitigate cultural underexposure and indifference, and how to limit and cease stereotypical projections. And then we have to figure out how to reduce the environmental triggers that feed imposter syndrome, as she mentioned in her talk. And then we have to address uncivil behavior immediately and think about models of restorative justice so that the person offended, as well as the person who may have inadvertently made the offense, can both grow from the experience. The problem, of course, is that mandatory training in cultural competence or mandatory training in implicit bias or diversity education often engenders resentment and resistance in the environment in which you're trying to drive change. And one of the things that we have to really think about is how we can best reach the learners to try to change their behaviors. And we also have to figure out what the situations are that warrant a specific type of training that's going to be effective in bringing them forward. For instance, if you wanted to do implicit bias training, you really might want to focus on situational implicit bias training, such that people who are writing letters of recommendation or performing evaluations of students are part of the group that's really touched here. If you're looking at trying to develop a diverse faculty, then search committees should have implicit bias training, but that may not be the same as implicit bias training in a clinical situation. So I think you have to do specific sorts of training to try to address the specific sorts of problems that you're trying to achieve movement in. But this is work out of Yale, colleague Darwin Boatwright's group, and they actually asked a question of medical students around whether they experienced discrimination and mistreatment in their programs. And this comes from the AMC graduation questionnaire from 2016-17. And what they found is that compared to white and Asian students, underrepresented minority and multiracial students reported higher rates of mistreatment. And the group that actually had the greatest prevalence of mistreatment were underrepresented minority female students, who bear the burden of both racial discrimination as well as sexist discrimination as well. And a study funded in part by the ACGME, and that involved the combination of the American College of Surgery, the American Board of Surgery, and ACGME. Carl Bill Moria out of Northwestern, his group, formed the first trial, which was really focused on looking at work hour, duty hour issues in surgery, but also asked questions specifically about discrimination and abuse. And this really landmark paper last year in the New England Journal showed that we could sample, or that they could sample, 99.3% of all surgical residents. And what they found by that almost complete sample is that almost 32% reported discrimination based on gender, 17% reported racial discrimination, another 30% reported verbal or physical abuse, that 65% of women in surgery reported gender discrimination, another 20% of all surgery residents reported sexual harassment. And that the people involved in this vary from patients and families to other resident colleagues to attending surgeons. They followed up with a paper looking at that racial discrimination component, and they found that of the folks who reported racial discrimination, that it was higher in African American trainees than any other group. And that when you looked at what was seen as racial discrimination in blacks, they felt that there was a different standard of evaluation for them in 38% of the cases as opposed to their white colleagues. That 16% said that they were denied opportunities that were made available to their white colleagues. And that slurs and hurtful comments were quite common at 25% of all surgical trainees who are African American. And that over half, 62%, said that they were mistaken for non-physicians in their environment. And that even by their team, they were mistaken as another African American person who may have been in the surgical training program at over half, 55.8% of times. The idea that minority students have a different experience than majority students in medical education really is pronounced in Lottie Derby's work out of Mayo, in which she suggests that if minority students are measured in their Maslach inventory scale, a measure of well-being, compared to their majority colleagues, that minority students actually have a better Maslach score, less burnout, than their majority colleagues. However, if those minority students have been the victims of discrimination or witnessed discrimination, their Maslach scores are much lower and they're more accelerated to burnout and depression. When you look at the sorts of things that minority residents have experienced in their training, they've reported, this comes from about 14 years ago, published in the Journal of the National Medical Association, where they asked residents what their experiences were. And they talked about discrimination, these differing expectations that we saw in the Bill Morio study, social isolation that we actually heard Chantal talk about, and then career consequences for the similar sorts of things that colleagues do and how they have to develop different coping styles. And one of the things they said was that overt discrimination was rare, but participants in that study believed that blacks were punished more harshly for the same transgression and expected to perform at lower levels than their white counterparts. They also felt that racism was at the core of many of those things that were used as critiques of their performance. And it tempers their imposter syndrome, their self-doubt. In an update of that study back in 2018, a group out of Yale again looked at the experience of minority residents in training and found that they were subject to a daily barrage of microaggressions and bias, and that minority residents were tasked as race and ethnicity ambassador in their programs. They were challenged with, again, negotiating the professional and personal while being seen as the other, even in their own groups. Lottie Derby's new work in 2019 looked at these microaggressions that minority students experienced. And what she found is that the depression symptoms that are exhibited by underrepresented minority students who've been victims of aggression, of microaggressions, are really driven by factors within the learning environment as opposed to individual traits. And this gets to that systemic racism that Chantal so beautifully laid out for us. And what Lottie Derby said is that medical schools need to do more to improve the learning environment for non-white students. And what happens when you are burned out? Because this is what happens when you are treated in this way in your environment. Well, your ability to focus wanes, and your engagement with work suffers. Their feelings, apathy, and hopelessness on the part of the individual who's subjected to this sort of treatment. A person may exhibit increased irritability or emotional exhaustion, or the exact opposite, potentially lability. And then there's the lack of productivity and poor performance. And when you're evaluated and you're burned out and performing this way, what happens? Well, you end up being evaluated more poorly than perhaps you should. And what we see in response to that is people who withdraw from residency program. And if you look at the bar graph here, the green being African American, the red being Latinx, remember that the number of African Americans is only about 4.5% of all residency trainees. The number of Latinx physicians about only 5%. That the number of people who withdraw, 51 out of a total of 636, is greatly out of proportion. If you look at the actual percentages, 8% of all those people who withdraw from residencies are African American. Another 6.1%, over the 5% of people who are in their program are withdraw from residency in the 2015-16 year. But if you look at the people who are actually dismissed, that's forcibly told not to come back to the residency training programs, you'll see that African Americans represent a much larger number than their numbers in residency training. And in fact, if you look at the percentages of all those individuals dismissed, anywhere from 10, 11 to 20% of the people who are dismissed from residency programs are African American. And then if you look by specialty, you'll see that 25.8% of all those people who were dismissed from surgery residency programs in 2015-16 were African American. And that 40% of all those people who were dismissed in OBGYN programs and obstetrics and gynecology were either Latinx or African American. And if you look at the relative risk of being dismissed in surgery, it's about sixfold if you're Black compared to white. In my discipline as an anesthesiologist, it's about tenfold greater if you're Black compared to white. In internal medicine, it's 12-fold. In pediatrics, it's 6.7-fold greater Black than white for dismissal. So when you look at the work of Bill Morio again, you'll see that not only is there gender discrimination, racial discrimination, there's verbal discrimination, physical abuse, there's sexual harassment, and even discrimination because of pregnancy or having a child situation at home. These all are contributed by attendings, the administration, co-residents, nurses, and then patients, family, and staff. And if you look at the frequency of this sort of behavior, you'll see racial discrimination. Of the 1,200 residents who reported that they've experienced racial discrimination in that given year, that almost 900 said that they have it a few times a year, and another 368 said it happens a few times per month or more frequently. And when things like that happen, what happens is you now start driving more depressive symptoms, and suicidal ideation actually even comes into play in many situations where residents have been the victims of this sort of behavior. So the impact on the healing of having an environment that's discriminatory really has to be addressed. And one of the new program requirements the ACGME put forward last year was one to ask all programs in partnership with their sponsoring institutions to provide a professional, equitable, respectful, and civil environment that's free from discrimination, sexual and other forms of harassment, mistreatment, abuse, and coercion. And this is true of students, residents, faculty, and staff. This is Christine Porbath, who spoke with the American Medical Association's Change MedEd Conference in 2019. She's written a book called Mastering Civility. And what she did is she asked the audience, if you work in an uncivil environment, raise your hand. And a good portion of the people in the audience who work in medical education raised their hand. They showed a list of about 10 words, some of that had more aggressive sort of connotations, others less, more passive. And then she asked you to keep your hand up while you remembered 4 words from the list. And when those aggressive words came up, the people who also raised their hands saying that that was one of the words that they recalled from that list were, oddly enough, the same people who had their hands up already saying that they'd worked in civil environments. And so what happens with incivility is that people miss information that's right in front of them. And those around incivility are more likely to have dysfunctional or aggressive thoughts and be unaware of the connection. And that the cost of incivility to your business is really more than you know. And people experiencing incivility may struggle to get off the sidelines and back in the game. And isn't that the sort of thing that when you're evaluated would actually prove to be negative? So now we bring it in the context of COVID. So now you've got doctors who are on the front lines who've been fighting COVID, who see a disproportionate impact on minority communities. They're taking care of folks in unprecedented numbers who are dying, sometimes alone. That takes a toll, drives the person to increasing levels of burnout. And now you add and superimpose on that the things that have happened most recently with the unprovoked deaths of African Americans at the hands of law enforcement community. And this woman in the corner here, Jasmine Marceline from the University of Nebraska, she says that she's cried frequently and been irritable, those sorts of things we describe with burnout, been neglecting most of my non-patient care duties, withdrawn from social media and virtual socialization with friends, exhausted physically and emotionally. It takes a tremendous amount of energy to walk this path, still put on a brave face, and pretend like nothing is wrong. Our physicians shouldn't have to do that. The impact that this sort of behavior takes on those individual healers is tremendous and very personal. And I really think that as institutions, we have to do something to address this next generation of physicians. As Chantal points out, that is happening in medical school. We see that it's happening in residency, and it is truly also happening to our faculty and folks who are in practice as well. So thanks very much, and I'll pass it on to the next speaker. Thank you very much, Marcine.